I think that this is also a very interesting question, and I don't think that at this point we have a clear answer for that. So, CAR-T have been used for several years, let's put it this way, as third-line treatment strategy. Now, we have already been discussing the potential role or how CAR-Ts are going to be moved to second-line treatment. There are prospective clinical trials that are looking at the possibility to include CAR-Ts in the first-line treatment strategy in patients with a special high-risk diffuse large B-cell lymphoma. Bispecific monoclonal antibodies are really also a very interesting treatment strategy. They are also very effective. But unfortunately, they cannot be used in most of the cases outside prospective clinical trials, although probably in the next few months, we are going to see some of them being approved. I guess that firstly by the FDA and secondly also by EMA. So we will have the possibility to have both treatment strategies to potentially be used in patients with diffuse large B-cell lymphoma. Nothing is black and white in medicine, and there are some eventually pros and cons regarding CAR-T versus bispecific monoclonal antibodies, and probably what we will try to do in the future is to try to combine both of them. There are some data out there that basically come from prospective clinical trials that indicate that bispecific monoclonal antibodies, so basically epcoritamab and glofitamab, are useful and are effective in patients that fail CAR-T. And in a small subgroup of patients, always in the setting of prospective clinical trials, the overall response rate of patients that have been treated with bispecific monoclonal antibodies because of a CAR-T cell failure are quite similar to the overall response rate that we can see with the use of bispecific monoclonal antibodies in other subpopulation of patients. So I think that this is one way to go, and probably just because of the label with which bispecific monoclonal antibodies will appear in the market, in taking into consideration that CAR-T in some patients are already approved in second line, maybe, let's say, the clinical community will be using CAR-T first, and then in those patients that fail CAR-T, they will be using bispecific monoclonal antibodies. But there is also, I would say, that quite a lot of interest to understand if bispecific monoclonal antibodies can be used as a bridging therapy for patients that are candidates to CAR-T. This is one area that needs further developments because we really don't understand if this is a clear possibility. But when we are talking not about second line, but eventually in third line patients, one of the issues that always come into our mind is how to optimize bridging strategies. And for patients that have been chemorefractory, the use of a third line or fourth line chemotherapy probably does not make a lot of sense because these patients are already chemorefractory, and maybe there is the possibility to use bispecific monoclonal antibodies that have a completely different mechanism of action and that can eventually give the patient some sort of disease control before taking the patient into a CAR-T. So this is an area that probably that deserves further analysis and that probably will be implemented in the near future.